per day, graduates per day, Bristol type 6 to 7 stools from Bristol type 4, small volume associated with fresh red blood mixed with each stool. History of tenesmus present. He also gives history of 1 to 2 episodes of nocturnal diarrhea without any improvement with fasting. Stools are non-greasy and non-bloating, flatulence, no history of anal discharge or itching. He complains, no history of fever. He also complains of abdominal pain, which is diffuse more in the lower abdomen, non-radiating, cramping type of pain, which is mild to moderate in intensity, aggravating with food intake and relieving with passing stool. Pain was not associated with visible abdominal distension, vomiting, constipation, ball rolling sensation, borborygmy, or any awareness of lump. History of significant weight loss present, 5 kgs over 2 months. He also complains of easy fatigability aggravated for the last 3 to 4 months without any history of giddiness, shortness of breath, and palpitations. No history of oral ulcerations or joint pains. No history of flushing, shortness of breath, or cough. He doesn't have any food intolerance and no history of recent travel, no history of blurring of vision, bone pain, easy bruising, gum bleeding, tingling, or numbness. Coming to the past history, no history of diabetes, thyroid, hypertension, or TB, no significant past surgical history. Personal history, he consumes mixed diet, bladder regular, sleep disturbed due to nocturnal episodes, not a known alcoholic, is a known smoker, 5 to 6 cigarettes per day for last 7 years. Family history, his cousin has similar complaints for which started on steroids followed by injections. Nutritional history deficit is 1100 calories. Coming to the summary, 25-year-old gentleman from Thrissur with no known comorbidities, known smoker, presented with complaints of small volume bloody diarrhea with nocturnal episodes associated with abdominal pain and history of significant weight loss since 3 months with no features suggestive of micronutrient malabsorption. And my syndromic diagnosis is chronic large bowel inflammatory diarrhea with weight loss. And my differentials are IBD, Crohn's disease, or ulcerative. In infections, could be tuberculosis and lymphoma. Neoplasm malignancy could be lymphoma.
DT, shall we have a break right now and then shall we proceed with questions?
You can do that, Dr. Suja.
Yeah. So why do you think that this is a case of explain why did you put a syndromic diagnosis of large bowel inflammatory diarrhea? What are the features which make you think that this is large bowel and not small bowel diarrhea?
Sir, more frequent stools and small volume stools, sir. Presence of urgency and tenesmus.
Okay. So the frequency of stools will be small. I mean, can you tell the differentiating points between small?
Sir, in large bowel there will be in large bowel there will be more frequent stools. In small bowel, less frequency. Frequency will be less.
And why is it so? Why is it so?
In large bowel, due to involvement of the rectum, rectum is a reservoir.
Okay, so due to the involvement of the rectal reservoir, patient will have urgency and will pass small frequent stools. Okay, 1, 2.
Difference, sir.
Yeah, other differences.
Volume, yes, sir. Volume will be less in large bowel diarrhea. More in small bowel, it will be more volume. Volume will be more.
Then.
And in large bowel associated with urgency tenesmus, in small bowel, borborygmy flatulence will be there. So patient complaints of borborygmy flatulence.
Yeah. So suppose we think that this is chronic large bowel inflammatory diarrhea, as what you said. Why do you say it is inflammatory?
Presence of blood and mucus
in the stools. Okay, right. So what are the odd points in your case? Like what are the findings which are against the diagnosis of large bowel alone? Or do you think all the findings are fitting into that?
Yes, sir. All findings are fitting into large bowel.
Okay. How do you, what was describe the pain that you described again?
Yes, sir.
No, just give a description. That will be fine. I think. Like, where was the pain located?
Oh,
I think it's
pain,
reverse.
lower abdomen, sir. Diffuse and lower.
Diffuse lower abdominal pain. How do you explain the weight loss?
Due to involvement of the mucosa, there will be, if mucosa is involved, there will be anorexia and severe weight loss.
Is it really so? Like, because large bowel, what is the main function of large bowel?
What did you say, that mucosa is involved, so there'll be weight loss?
Sir, if
What do you mean by that?
extensive
So what Dr. Sujan is asking you is that, is there any difference between small bowel and the large bowel mucosa being involved? Will the effect be the same?
malabsorption will be present, sir, in proximal, in small bowel and proximal large bowel involvement.
Very good. And in colonic involvement, what will be the classical problem? What is absorbed mainly from the large bowel mucosa? It's mainly the water which is absorbed by the colonic mucosa. So small bowel mucosa, once it is affected, it could be resulting in malabsorption and maldigestive symptoms. But large bowel predominantly does not have significant weight loss along with it. Very severe inflammation, very severe disease, long-standing chronic inflammatory disease can have inflammatory interleukins getting released, and that could cause weight loss. But frankly speaking, just colonic mucosal involvement very rarely results in significant weight loss.
Okay.
Can you tell me what is protein losing enteropathy?
Um, Due to loss of protein in the stool, there will be hyperalbuminemia and patient may present with the generalized edema.
All right. So is protein losing enteropathy a part of the large bowel diarrhea, or it's a specific for small bowel, or
Small
it can
bowel
happen in
diarrhea.
both, or it can
Small
happen in both? Why, if there's a lot of inflammation in the colon, will there be loss of protein from that surface, or there'll be no loss of protein?
Sir, more loss of
I'm saying, with the large bowel inflammatory diarrhea, can it cause protein losing enteropathy?
predominantly small bowel involvement will cause protein losing enteropathy.
Oh, your question, you can't change my question according to your what you want to say. My question is very specific. Can large bowel diarrhea have protein losing enteropathy?
Yes, sir.
Don't get worried. I mean, you have to say that confidently.
Yes, sir, it can.
Okay.
I think one of the classical tricks is to learn from your examiner. Like, examiner will be feeding you with ways out of the problem that you're dug. So sir was giving you a clue as to how protein losing enteropathy could be the reason for one of the weight loss that this patient was having. Okay, fine. Right. This you mentioned about the family history here. Like, there was one patient who had a family history of similar illness. How is it significant? Like, what among the list of differential diagnosis, does it help you in any way?
Yes, sir. IBD can occur in families, sir. And any colonic malignancies can.
Okay, fine. But what was the
patient is on steroids, so malignancy is less common.
malignancy is unlikely to be the cause. Okay, fine. In the personal history, does it help you in excluding a diagnosis or bringing in a diagnosis in some way?
Personal history.
Addiction history, yeah. He's a smoker. That does that help you in making tilting your diagnosis in favor of some illness or the other?
Yes, sir. Crohn's disease, smoking is a risk factor for IBD, sir. Crohn's disease.
Okay, fine.
So is there any family history can be there in tuberculosis?
Sir, if close contact history is there, it is significant.
So how do you think ileocecal tuberculosis will spread from one family members to another family member?
If,
I can understand that for pulmonary tuberculosis.
yes,
But
sir.
how do you think intestinal tuberculosis will spread from one family member to another family member?
Sir,
Not a difficult question. So we have to know that how the abdominal tuberculosis take place. Intestinal tuberculosis often is there pathogenesis of abdominal tuberculosis. You know, intestinal tuberculosis rather. Where does the tubercular germs come there?
In from
We've gone into very basics. We are not getting into difficult scenario. We are talking about what is the pathogenesis or the source of infection in intestinal tuberculosis.
Hmm.
Do you have
Not
other student is already there, also there? Is
yes.
he already hooked
Yeah,
on?
Dr.
Maybe
Anup is also there, I think.
can he answer that question?
Anup, please take up the question.
Actually, we are on same similar laptop, sir.
But you can answer.
because of
You can sit next and you can answer if she is not able to answer.
Ingestion of the bacteria from the pulmonary sputum ingestion.
Okay, okay. And that if there is a active tuberculosis in the pulmonary area, that can spread from one family member to another family member. That is one way in which the intestinal tuberculosis takes place. What else? What are the other ways in which intestine gets involved?
Lymphatic.
Lymphatic. So there may be disease in the lymph nodes, and there can be retrograde movement from the lymph nodes to the intestines. All right.
Yes,
Yes.
sir.
All right. Now there's somebody who has asked question is that why there can be fecal transmission from one person to another person.
I don't think.
That must be very, very rare. I mean, I'm not sure whether that has been documented. All right.
Yeah, I think.
The cutaneous markers of malignancy, did you mention?
Sir, in
What are the cutaneous
examination.
markers of malignancy?
Examination only, sir.
Oh, no, she mentioned no. Okay, not yet.
Shall I continue?
Yes, you can continue.
Yes.
Coming to general physical examination, patient is ill-nourished, well-oriented to time, place, and person. Vitals are stable, pallor present, no pedal edema, JVP normal. Systemic examination, eyes normal, no bite or spores, no lid lag, oral cavity normal, neck no thyroid swelling, skin no ecchymosis or rash, no cutaneous markers of malignancy or no cutaneous markers of TB or IBD noted. Nutritional assessment, BMI 16.1. It is on lower side, and tricep skin fold thickness, mid-arm circumference, and hand grip are on lower side. Coming to the systemic examination, para-abdomen inspection is normal. On palpation, mild diffuse tenderness is present, no like local rise of temperature, no guarding rigidity, no palpable organomegaly or palpable mass. Percussion normal, auscultation bowel sounds heard. Per rectal examination, no external skin tags or hemorrhoids. Anal fissure noted, no anal tone normal, no palpable mass or no blood. Other systemic examinations are normal.
Next point, Deepti, like, I mean, at the end of your examination,
Yes.
are you wiser in any way? Did you get any additional points?
No, sir. Except for
basically,
low BMI.
Yeah. So
Any
basically, I
evidence
think
of micronutrient deficiency? Any evidence of micronutrient deficiency?
No, sir.
No, sir.
I think two additional points that you got here, or two findings in history which you confirmed here, was presence of pallor and a low BMI. I mean that supports your diagnosis of the patient having an organic disease rather than a functional disease. Though from the history it was very evident. Right. Okay. So gathering your history and your examination, what will be your list of differential diagnosis? Is there any change in the differential diagnosis, or would you like to continue with the same order?
Same differential, sir.
So
First
IBD will be a first diagnosis. What IBD? What variety of IBD?
Crohn's disease.
Why do you think that Crohn's is the first diagnosis?
Abdominal pain, sir. Abdominal pain is predominant in Crohn's.
Okay, so if abdominal pain is involved, if the patient presents of complaints of means significant abdominal pain, which layer of the bowel is involved? What does it tell you?
Muscularis, sir.
Yeah,
Muscularis.
if it's a crampy type of pain, it is usually because of the muscularis involvement. If it is a persistent localized pain, it is linked to be because of serosal involvement causing localized peritonitis.
Oh.
Okay, so presence of blood and mucus in the stools, which layer of the mucosa is involved? Which layer of the bowel is involved?
Mucosal ulceration.
Okay, mucus involved. So you have a disease which is involving predominantly the large bowel and has involvement of the small mucosa and the muscularis.
Yes.
Okay, that is what you have put forth, I think, right?
Yes. Yes.
So there was bleeding per rectum, if I got it right.
Yes, sir. Bleeding per
Now,
rectum.
Dipti, can you tell me whether the bleeding is more common in Crohn's disease or in ulcerative colitis?
Ulcerative colitis.
So does that take you away from? So the only thing which you suggested in favor of Crohn's disease is pain.
Is pain, sir. Yes, sir.
So, but there are certain features which are against Crohn's. Are there some features which are more favoring ulcerative colitis?
Blooding stools, sir, favoring ulcerative colitis.
So can you give me a rough idea of how many percentage of patients with Crohn's disease would have bleeding per rectum?
So 20 to 30% will have bleeding PR, sir, in Crohn's disease.
So can you also tell me about if there are 100 patients of Crohn's disease, how many will have small bowel, how many will have a large bowel, how many will have a combination of small bowel and large bowel?
Predominant percentage, sir.
Yeah, approximate. No?
Most of them will have distal small ileum and proximal small bowel in proximal large colon involvement, followed by distal.
40%. 40% will have ileocolonic, 30% small bowel, 20% Crohn's colitis, 10% perianal.
Network. Hello.
Hello.
Yeah, we can hear you. We can.
Okay.
So I think it's almost one third. One third will have both small and large bowel. 1/3 will have only small bowel, and 1/3 can have large bowel alone. Or some books have mentioned 40-30-30, but it's okay. So 1/3 each. Now there is a small question. Somebody from Dr. Srinivas has asked, why small volume in large bowel diarrhea? Can you answer that question? Why the volume of stool is small in large bowel diarrhea? You already answered that, but can you again answer that?
Due to rectal involvement, rectum acts as a reservoir, so patient will have more frequent small volume stools.
So it acts as if the rectum is involved, it acts as an irritant that the moment the stool is there is a desire to pass stool, and so there will be more frequency and less amount. But it may not hold true for the right colonic involvement. It's more common for left colonic involvement. Fine, let's go on. I think we are overshooted our time.
Coming to the investigations, HB 11.5, ESR is elevated 65 and CRP is 4.3. Stool examination normal and serology is negative. Colonoscopy was done which showed ileal aphthay and linear ulcers involving from the ascending colon to the rectum. These are the ulcers, and anal fissure was noted.
Now, tell me one thing. If you are given a choice, can you go to the first slide, please, of the investigations?
Yes.
Of the investigations. No,
yes.
Go back. Yeah. So you did a stool examination. You find RBC to be present. And what do you mean by serology? What serology are you talking about?
Sir, HIV
serology. Then you have to tell now. This is serology can be hundreds of things.
Okay.
So you're talking of HIV serology.
Yes.
Are there any value of doing other serology? You've heard about ESCA, P-ANCA, C-ANCA. Any of these are of value?
P-ANCA we can Sir, we will be able to differentiate between Crohn's and ulcerative colitis.
What about ASCA? Anti-Saccharomyces services antibody.
Not sure.
You've heard about this?
Yes, sir. Yes, sir.
All right. So it does not have much value, though initially we used to think that it is classical of Crohn's, but now we know that it can be false positive in any disease, including tuberculosis. There are data
Okay.
from All India Institute of Medical Sciences, from SGPJ Lucknow, and many other. All right, let's go on.
Coming to CT abdomen, there is a long segment enhancing circumferential wall thickening, a maximum thickness of 7.5 mm, involving descending colon, sigmoid, and proximal rectum. Mild pericolic fat stranding was noted and no evidence of stricture. Biopsy was done, which showed diffuse active proctitis with granuloma, focal ulcerations of the mucosa present, cryptitis and cryptapsis noted. Lamina propria showed dense inflammatory cells, which are neutrophils, lymphocytes, and plasma cells. So this is the histological slide showing granuloma.
So
And
if
the
I still insist on saying that this is tuberculosis, go back. I say if I insist on that this is tuberculosis, how do you counter me?
Inflammatory cells, lymphocytes will be predominant in tuberculosis.
What is there in this?
Neutrophil.
So you mean to say you get neutrophil in Crohn's and you get lymphocytes in
No,
tuberculosis?
I mean predominantly it will be lymphocytes in tuberculosis.
Is that the main way of differentiating as histology? Are the granuloma characters?
Granuloma
Granuloma.
size. The size of the granuloma will be bigger in tuberculosis and smaller in Crohn's.
Microgranulomas.
Multiple microgranulomas.
Okay. Now you are lucky that you got a granuloma. Otherwise, what percentage of patients will get granulomas? They are not very common.
Yes.
Somebody has said, what about caseation? Is there any caseation?
Non-caseating.
So non-caseating do not differentiate tuberculosis from Crohn's. But if the caseation would have been present, it would have helped you in differentiating. It would have gone in favor of tuberculosis, isn't it?
Yes, sir.
Somebody has said, Dr. Manmohan, that can it still be ulcerative colitis?
Granulomas are present, it favors Crohn's disease.
And that if I got it right, that there was a small bowel involvement, na? You found a small bowel
Ileum
involvement?
after present, sir. Yes, sir.
But is the involvement continuous in the colon? I missed that.
Yes, sir. From ascending colon to cecum, there are linear ulcers, sir.
But rectum is spared?
Rectum also involved.
So is the disease pancolitis from rectum to cecum?
Yes, sir.
Okay.
Diagnosis is IBD, Crohn's disease, A2L3B1P, CDI 347, which indicates severe disease. So patient was, patient had developed symptoms in the first week of November, and he was on OTC drugs for 1 month, following which he consulted and he was investigated and was diagnosed as Crohn's disease, and patient was started on steroids in December first week. Symptoms subsided. He responded. Then steroids were tapered. But after tapering, symptoms had recurred, and after discussing with the treatment options with the patient and bystanders, patient was started on adalimumab. Now his symptoms subsided.
So this is what was done. If you are given the option of starting the therapy in the very beginning after you have done a colonoscopy, what are the various ways in which you can handle this patient?
So, patient is an young patient.
Are you agreeing with whatever has been done, or there are some alternate way of treating this patient?
We can go with the top-down top-up therapies. I mean, starting with the anti-TNF biologicals, because patient is an inpatient, severe disease, and perianal involvement is there. We can start him on adalimumab directly.
Okay. So why are you talking of adalimumab only? There are other biologics also?
Sir, infliximab and sickimab is there.
Infliximab and what else did you say?
Vidolumab and
Vedolizumab. Okay.
Lutsicim.
That is not available in India. To my knowledge, would say is not available in India, but Vido is available. So is adalimumab and infliximab. Somebody is asking you, Swambhu from Calcutta, as to can this be backwash ilitis complicating ulcerative colitis?
There is a possibility is there, but because of biopsy showing granuloma, we took it as a Crohn's disease.
How common is anal fissure in ulcer?
Anal fissure in ulcerative colitis perianal.
So you have described certain things, like you said epithoid ulcers,
Yes.
you said anal fissure. So these and granulomas, all these point towards a Crohn's disease rather than ulcerative colitis. But we also know that a small percentage of patients may remain unclassified in spite of that, and they may have a combination of Crohn's and ulcerative colitis. And the majority of them ultimately turns out to be Crohn's disease on the follow-up. So any comments from Dr. Shuyan?
I think like sir has summed it up very well. Like this mostly the features of after involvement, presence of pain in history, after ulcers, and this was not a continuous involvement. Patchy colon, but all segments of the colon were involved. Presence of anal fissures and presence of granuloma. I think like point more towards of a diagnosis of Crohn's rather than ulcerative colitis. Rest everything I would totally agree with sir. I think like I mean our message to put the same thing only forward.
So there is a question that whether we should do a capsule endoscopy in this patient.
Already CT abdomen with enterogram was done. It will be enough.
So I think capsule is not going to add much to this information what we have. If the small bowel would not have been involved by seen by CT scan, then there could have been a possibility of doing a capsule to look for the small bowel evaluation. But then we have to also understand that in Crohn's disease, if you do a capsule, the risk of retention is not negligible, if I can use that word. It would be a little higher than when you do for obscure GI bleed. So if you're doing it in a suspected Crohn's, you have to be careful that the capsule doesn't get stuck. So since we have 1 minute, Dipti, if we do a capsule endoscopy and it gets stuck, what are the options? See, if you do a capsule today and after 3 days, you find that the capsule is still there, what will you do?
Enteroscopic removal.
Search.
No, I said, I mind my question. I'm saying 3 days later, you find that the capsule is still there. Will you remove it? So what's the definition of capsule retention? So there's no need to rush into removing a capsule. I think you can easily wait for some time. It's hardly a retained capsule has ever caused a major problem. Hardly. I would say very, very rare that a retained capsule. So there's no need to rush. If there is a Crohn's disease and there is a capsule is stuck, it may be that it is because of the narrowing or a spasm. And once you give the treatment, the capsule may pass by itself. And normally it is recommended that for 1 month, there is no need to rush into removing. And of course, if you decide to remove, you have enteroscopy as your first option to remove it. You agree, Dr. Sujan?
Yeah, sure, sir. Sure.
So I think there are some of the questions which we have already taken up. There's a question that can this be IBD-U, which we discussed already, that there is a combination of features sometimes present, so you can call it IBD-U. But as rightly presented, this case is tilting more towards Crohn's disease than anything else. Somebody has said retention can be for 2 weeks. It's variable, but nowadays, mostly people say that there's no need to rush into removing the capsule. Role of ASCA, we have already discussed. So I think most of the questions which has been put forward in the chat box has already been addressed. So if fine, we can go to the next presentation.
Yes, sir. No.
Sir, is my slides are seen?
Yes.
Okay, thank you, sir. Good evening, everyone. Good evening, professors and teachers. Today, for the Journal Club, the topic for discussion is one of the recent upcoming and newer technique, which is going to be established in future mainly. It's a development of artificial intelligence-based cirrhosis ECG score, an electrogram ECG-based deep learning model in cirrhosis. This is published in the American Journal of Gastroenterology in this edition, March 2022, the recent edition.
Click once on the presentation.
Yes, sir. Yes, sir. So, coming to the topic.
Okay.
Introduction. Sorry. So it is a deep learning based artificial intelligence model and is established on convolutional neural networks. So two things are coming. It's an artificial intelligence model and on convolutional neural network, which I will explain in the next slide. And this network, this score will dictate cirrhosis related signals on the ECG, and they produced an artificial intelligence ECG score that can correlate with the disease severity. So what they did that this is the convolutional neural network, which is represented in a simplified form. Actually, it's a part of deep learning. Deep learning means a part of machine learning. It's a part of artificial intelligence. So the thing is that in the image we can see that a bird is given a bird pixel. The pixel of the images are given into the input layer to the hidden layers, then to the output layer. In the hidden layers, their convolutional networks are formed. Based upon the images, these networks are formed and the final report we are getting. So when we give an ECG, a normal ECG is given, we will get an output of normal ECG. When an ECG with cirrhosis is given, we will get an output, this ECG, ECG is of a cirrhosis. But we won't be able to find out what is going inside the convolutional network and which pattern is making to tell it output as cirrhotic ECG. That is not available to be get out from the convolutional network. That is usually what happens with the convolutional network. So what the methodology they did is that this was conducted in Mayo Clinic. In their 3 transplantation centers from 1988 to 2019, 6,603 liver transplant patients. Of that, 975 were excluded who were non-cirrhotics, and 5,628 cirrhosis patients. Of that, 5,212 digitalized 12-lead ECG was available. They were matched with the 20,700 in the 1:4 ratio. They match with the age matched and sex matched controls, so that a total of 25,940 eligible patients for the model is good. Every artificial intelligence model, they divide the set into 3 sets: the training set, validation set, and the testing set. I already mentioned that the convolutional neural network, we have to train the convolutional neural network. This is the normal ECG. This is the ECG with cirrhosis. So they use the 70% for training set. This is a standard thing, 70, 10, 20. Usually the 70 for training set, 10% for validation set, and 20% for the testing set, in which the final testing is done. So coming to the model development, and finally what they got is a binary result from 0 to 1 that we will explain. The binary classification is gone. The model input what is being given is a 10-second 12-lead ECG. The output being the likelihood of a ECG being from a patient with cirrhosis. So how they assess the model performance assessment? So they developed a ACE score, a continuous value between 0 and 1, an ROC curve from the validation set to select an optimal score threshold for binary classification. And the validation set, they plot an ROC curve. Then the CNN was applied to the test set. To minimize the confounding factors, they matched matched with the age, sex, comorbidities, systemic hypertension, diabetes, cardiovascular disease, chronic disease, and lung disease. So all the confounding factors they matched. So and they plotted a severity, the binary classification to melt sodium. And longitudinal changes. How they assess the longitudinal changes is that the changes of AC score reflect severity of patients of liver transplantation or time. What they did that of the 547 transplanted patient, they investigated for long-term care at Mayo Clinic, and they followed the ECG for long term. So a longitudinal picture also they got from that. Also, they did in additional validation 843 patients, a distinct set in which they had an ECG 6 months prior to the development of cirrhosis, and compensated cirrhosis patients. They both ECG they had ECG which was 6 months prior to the development of cirrhosis, and the ECG at the time of cirrhosis. Compensated cirrhosis. This was an additional validation set, and these scores were compared with the original controls and patients requiring liver transplantation. So they validated in these forms, and this was their baseline characteristics of the 25,940 with the control of 20,740 and cirrhosis of 5,212 patients. These are the things which we will tell in the next slides. So how the model performance in the test, how the model performed. It's very interesting to see that when the 10-second 12-lead ECG, that is a standard ECG they gave, the area under curve was very good of 0.908. And even when the 2-second of the 12-lead ECG, only 2 seconds was given, then also the area under the curve was 0.908, which showed that the area under the curve didn't change with 10-second to 2-second. Also, when the 10-second 6-lead ECG was given, the area under the curve was 0.886, and 10-second a single lead ECG was given, this area was 0.842, which means that a 10-second single lead ECG itself is giving a good value, which means that these things can be incorporated into wearable devices. From the wearable devices itself, will be able to predict at approximate a range of MELD and all those things in future. So what they did that they matched the comorbidities in the model. They matched the cardiovascular disease, hypertension, diabetes, chronic kidney disease, chronic lung disease. And even after matching, the area under the curve for the model, before matching was 0.908, and after matching, no much difference. It is 0.89. Then, the sensitivity also was 84 to 83 only, and specificity also 83 to 81, which means that after the matching also, the model performed very well after matching the comorbidities. Also, the subgroup analysis of the was given male, female, under 40, between 40 to 49, how the sensitivity, specificity, positive predictive value, and the odds ratio behaved. Everything was almost similar in all age groups. And how they got based upon the etiology of the model with a different etiology, how they got the etiology, sensitivity of the model. For the NASH patients who did follow up the model, the sensitivity of the model was 92.4%, which is the best one they got. The autoimmune, biliary, cryptogenic, viral, and other liver disease was more than 80%, while the HCC transplant patient was the lowest with 73.6%. So this is the value that got. This the left side which I am pointing is the AC score from 0 to 1, a binary model, and the down thing I am showing is the MELD sodium score. So when the AC score was of 0.10, 0.125 like that, the MELD was of range of 6 to 10 range. And when the MELD AC score increased, the MELD score is increasing up to 20 to 25 to 20 to 30, 25 to 30. It was progressively increasing. And after that, it was a static model, because means that it was able to predict up to a MELD score of 25 to 30. So the range. Sir?
Can I interrupt you? Can you just remind me as to how was the AC score calculated?
1 second, sir. AC score, actually, it is a the thing is a convolutional neural network model, sir. The thing is that.
No, that I understood, but
it is from 0 to 1, a binary model output. They are giving 0, 0.1, 0.2, 0.3, like that. The scores comes. They haven't told how the
based on the ECG. This is based on the ECG.
Yeah, yes, not based on the ECG output. They based on the ECG output. The system is giving a binary model. They haven't told what is the exact formula or exact definition for the binary model.
Okay.
Okay, sir. So from low AC score, the score increased. The MELD sodium score was static up to 0.75. At the AC score, the MELD was 20 to 25. Then it was a static MELD. So it was able to predict properly up to 25 to 30 MELD. And the better thing is that they did for the liver transplantation patients. The thing is that the 0 is the point of liver transplant. At the time of the liver transplant, whose MELD was up to 20 to 25, the score was high. The score declined after the year of transplant. By the second year of the transplant, the MELD score became almost, sorry, the AC score became almost normal. Almost normal means low range, and it was followed up to more than 5 years. This shows that before the transplantation, when the MELD was increasing, the score was increasing. And after the transplantation, the MELD and the liver cirrhosis, new liver was got, the AC score was decreasing. Everything shows that the AC score was very much accurate in this scenario. So they also compared the relationship within the sum of the markers, the MELD sodium, the total bilirubin, the INR. All these things showed a positive correlation with the p-value significant. MELD sodium, total bilirubin, and INR, while the platelet and the sodium showed a negative correlation with the significance, p-value significant. So coming to the discussion, the model, the CNN model was able to differentiate between ECG from patients with and without cirrhosis with excellent accuracy. And the model performed well after matching the comorbidities also. The AC score was associated with the disease severity, which we told by the MELD sodium and determined by the MELD sodium and other individual markers also. And the trends in AC score before and after reflect the progression and resolution of the cirrhosis, which I already mentioned. So what is the proposed theory? As we all know that cirrhosis causes cirrhotic cardiomyopathy. The theories are, in patients with portal hypertension, there is an increased production of activity of vasodilators, such as nitric oxide, carbon monoxide, and endogenous cannabinoids within the splanchnic vasculature. Also, the cirrhotic pathological state is known to have a decreased vascular reactivity to the vasoconstrictors. The vasoconstrictors also won't be acting that much. So there will be a generalized vasodilatation. These agents may directly affect the cardiac endothelium and myocytes, also leading to subtle ECG changes. In addition to these physiological changes, causes splanchnic vasodilatation and reduction in vascular resistance that lead to compensatory hyperdynamic circulatory state characterized by increased heart rate and cardiac output with low mean arterial pressure. These compensatory changes also will affect the ECG. The hyperdynamic circulation, which will affect the RAS system, the sympathetic nervous system, and antidiuretic hormone axis, which will lead to hypervolemia and ascites. Also, the cirrhotic stage can result in the vasoconstriction, in intrarenal vasoconstriction, and results in hepatorenal syndrome, which all accounts for the vascular changes in the cirrhosis. So, to summarize, it is said that the hepatic circulation, increased hepatic pressure, increased portal pressure, release of vasodilators, progressive fibrosis, endothelial activation. In the splanchnic bed, arterial vasodilatation, reduced splanchnic pressure, reduced intravascular blood volume, systemic circulation, which all results in increased cardiac output, increased heart rate, reduced systemic vascular resistance, reduced mean arterial pressure, neurohormonal, the increased plasma renin activity, the RAS system, all leads to the cirrhotic cardiomyopathy, which is dictated by the systolic dysfunction, diastolic dysfunction, and supporting criteria. The systolic dysfunction, which is include one of the following: blunted increase in cardiac output on exercise, volume change, or pharmacological stimuli, or resting LVF is less than 50, or diastolic criteria, average ejection wave E by E more than 14, or septal E velocity less than 7, lateral E velocity and tricuspid velocity in these ranges. And electromechanical abnormalities include abnormal chronotropic response to stress, electromechanical uncoupling, prolonged QTC, heart chamber arterial atrial dilatation and ventricular thickening, increased BNP, and increased troponin. So, what are the general ECG changes? What we usually describe classically in cirrhosis is that most common is the prolonged QTC interval. The mechanism for the prolonged QTC interval is increased. One is the increased sympathetic activity. The second one is these molecular ions, molecular defects in the myocardium, molecular defects in the myocardial potassium and calcium channels, and this cardiotoxic substance because of the photosystemic shunt which affect the heart. This causes the prolonged QTC interval. Second one, the low QRS voltage in presence of ascites. The third thing is that the heart rate variability, which is usually present in a normal human being, is whose sympathetic system and parasympathetic system is normally acting. So there will be some changes in the ECGs in the heart rate during exercise and rest and all those things, which is lost in the cirrhosis, which is decreased in cirrhosis, and the degree of decrease will be more in hepatic encephalopathy. And also the short TP, when a tangent is drawn from the top of the T wave to the bottom of the T wave, the distance, that is the TP-TE interval, it will be short, and this shows a high mortality in liver transplantation. It is classically described. So the ECG changes are subtle and it is highly variable, and we can't predict this ECG, this cirrhotic patient will have this ECG. That's a thing where it comes the convolutional neural network and all those things. So the thing is that the convolutional neural network is not constrained by the common known intervals and waves, but instead analyzes thousands of ECG waves forms to simultaneously process multiple non-linear subtle patterns and combination of features. That is the black box nature of the convolutional neural network, which we can't find out. So it is 100% from the artificial intelligence model and CNN is that it is not on the simple waveforms or just a pattern recognition. It is inside the new connections forms inside the convolutional neural network, which makes the system to think the artificial intelligence and to find out the correct diagnosis. So the model performance did not change between 10 seconds and 2 seconds of the 12-lead ECG, suggests that there is not relying for time-dependent patterns such as heart rate, but rate instead of waveform morphology. The model was promising even with a single-lead ECG for incorporation in a app-based wearable devices. AC score involvement after liver transplantation suggests that the CNN is capturing predominantly functional aspects rather than more ingrained structural rearrangement of the electrophysiological system. So limitations of the study, I mentioned the black box nature of the CNN, which we can't decode it out. Then this is a retrospective study which was done from 1988 to 2016. So the retrospective nature and large cohort precluded an accurate assessment of relationship between ACE and clinical manifestations of advanced portal hypertension. The association of AC score with the presence of ascites, hepatic encephalopathy, pulmonary vascular resistance, and frailty will be important to elucidate in further studies, which were not assessed in this study. And the potential limitation is generalized external generalizability and not validated in external cohorts. So for the summary, the patient got cirrhosis, which caused the circulatory changes and cardiac changes, some changes in the ECG, which is given to the deep neural network, which was first trained, validated, and given to the testing set. And finally, we got a binary model of AC score between 0 and 1, which was put into the ROC curve, which showed very good validation. So, thank you.
So, Dr. Panakal, you have any comments?
Okay. I know that A score is dependent on the waveform, not on the waveform. It's the interpretation of the ECG by the artificial intelligence. A score.
Sorry, it's told like it is assessed on very functional and which we can't identify from the waves. What the very small, minute pixel-based changes in the ECG. That is usually all neural networks do. Not typically QT prolongation or TPT interval, not based on those things they are finding out.
I'm totally stamped by this article. I have not seen this article, but I'm totally stamped that now we are entering the era when looking at the ECG, we are going to say that this patient has cirrhosis and this patient does not have cirrhosis.
Yes, sir. Actually,
let me complete. So I think what is very interesting is artificial intelligence is in thing, and I think if we don't understand all these, including deep neural network and convoluted neural network, then we are going to be left behind in the race. But then what is very interesting is that we are trying to diagnose cirrhosis by looking at ECG. We know that there are cardiac changes, but till now we had a concept that these changes are non-specific and cannot actually be reproduced. Now, my points are 2 or 3 to you, if you have reviewed the journal in very well, is that if we give this artificial intelligence a patient with cardiomyopathy, will it be able to tell me that this is because of primary cardiac myopathy vis-a-vis this is because of cirrhosis? Because these changes, if they are because of the cirrhotic cardiomyopathy, I'm sure these changes can be there in cardiomyopathy of non-cirrhotic origin also. So can the artificial intelligence differentiate between primary cardiomyopathy versus secondary to cirrhosis? And number two, you rightly said that 70% is training, 10% is testing, and 20% is validation, which is the usual formula, which goes, some people use 70%, some people use 75%. But when you put the data, are you talking only about 30% data? Are you talking about testing and validation? And what's the difference between testing and validation? When you say testing and when you say validation, what's the difference between the two categories? Training, I understand that you are telling the computer that this patient has cirrhosis and this is the ECG. Then what's the difference in testing and validation? And the third issue which I have is this is a study which is done in patients who underwent liver transplantation. So obviously these are very severe cirrhotics. Whether these are bad cirrhotics because they would have required transplant, and you rightly said in non-cirrhotic liver transplant, the results were not as promising as they were in cirrhotic liver transplant. So is it reflecting cirrhosis or is it reflecting advanced cirrhosis?
Sir, shall I?
Yes.
Sir, the first thing is that the cirrhotic cardiomyopathy and other cause of cardiomyopathy, actually they have been included, or the inclusion criteria, exclusion criteria, they didn't tell about these things about the other cardiomyopathies. But the thing about artificial intelligence and convolutional neural network, it was, when I read it, is told that the ECG changes which we can't dictate, subtle changes, maybe on pixel based changes, it is minute pixel based changes they are trying to identify. Actually, the artificial intelligence, Google has a software for detection of CT abdominal.
I understand. What I'm trying to say is that if you give to the artificial, you have given here thousands of images to the artificial intelligence of patients who are cirrhotic.
Yes, sir.
And you say these are the ECG changes. Now,
Yes,
when you test them, have you given non-cirrhotic patients who can have the similar ECG changes, and there may be a cardiomyopathy of other types which may have similar ECG changes? So will computer tell me that this is a cardiomyopathy because of cirrhosis, or this will tell me that it is cardiomyopathy?
Actually, the article didn't tell anything about the cardiomyopathy outside cirrhosis, actually, sir. They haven't discussed anything about the other cause of cardiomyopathy.
And what about early cirrhosis?
Yeah, actually, they have included cirrhosis only, sir, patients. Those I wanted to tell that, see, this slide showing 6,000 liver transplants, those 975 patients.
You're not understanding. What I'm trying to say is that these are advanced cirrhosis.
Yes, sir.
Because nobody will do a liver transplant in an early cirrhotic, compensated cirrhosis. So
yes,
what
sir.
happens in compensated cirrhosis?
Actually, they validated with that also, sir. Actually, I will show you. This thing. An additional validation, the performance model was tested in a distinct set of 843 patients with the earliest stage of disease, namely compensated cirrhosis. ECGs were obtained for all these patients at most 6 months before the diagnosis of compensated cirrhosis, and according to the clinical documentation, the distribution of AC score was compared with the original controls and the patients with cirrhosis requiring liver transplantation. Hello, sir.
I think, yes. I think artificial intelligence is such interesting aspect. But when you read an article like this, you really start scratching your head as to where are we going. Dr. Robert Panakkal, Dr. Sujan.
I think two of the most important points that we wanted to put forth is that the upcoming importance of artificial intelligence and the need of keeping yourself updated with what is new in this. Secondly, like more and more talks are going on regarding the liver heart axis. So probably that may also be rolled. Like, I mean, rather than the cirrhotic cardiomyopathy, which we were aware of, which is occurring more towards the later aspects, as was shown in the study, cardiac changes and ECG changes do happen from an early state. So probably the relationship between heart and liver starts much more earlier than the last stages of cirrhosis.
So while this is very interesting, since we have a couple of minutes, can you tell me where are the artificial intelligence in the gastroenterology being used in other areas?
Actually, in our endoscopy, the confocal endoscopy, which uses the artificial intelligence to detect the pit pattern and the changes in the polyp and whether to detect it is malignant. While doing endoscopy, it will shows like 99% malignancy, 70% malignancy. It is used in
You're putting too many strong words. Are you talking of confocal endomicroscopy?
Yes, sir.
Confocal endomicroscopy is different from magnification endoscopy.
Okay, sir.
Which area are you talking about?
Actually, the advanced artificial intelligence based endoscopy
Can
where
you tell me what is confocal endomicroscopy? You just use that word.
It's using the laser light to detect the. I'm not sure, sir.
That's the best thing to do. So actually, it is used for magnification endoscopy. It need not be confocal. Confocal is a different type of endoscopy. We're not going into the details of that. But primarily, it is used for detection of polyp and for characterization of polyp.
Yes, sir.
So the machine can tell you that there is a suspected polyp because it appears as an elevated lesion, or it can also tell you whether it's an adenoma or whether it's a non-adenomatous polyp.
Adenomatous polyp. Okay, sir.
Any other area?
Sir, it's used in CT and MRI. Actually, the artificial intelligence, which is able to detect with a very good accuracy. Lots of trials are going in for the CT, MRI, PET, for diagnosis of the intestinal all body imaging.
Fine, but more particular to gastroenterology, it is used for IBD, inflammatory bowel disease, to find out whether there is disease is active or inactive.
Yes, sir. Yes, sir.
It's also being used for finding out whether you have reached cecum or not. To find out whether the machine will tell you that this is cecum or this is not cecum.
Yes,
and
sir.
Also for grading the bowel preparation.
Okay,
Whether
sir.
the bowel preparation, as you know, is the Boston classification. So what type of bowel preparation it was. So these are some of the areas where the work has already been done and is being used. But this seems to be very, very interesting. I am really very, very engrossed by this article. Would like to read again.
Yes,
Thank you. Any final comments before we close down, Dr. Robert, Dr.
In
Sujan?
future, we should be in future we should be familiar with the artificial intelligence. I think all these terms, deep learning, CNN, all things we should be aware of. As gastroenterologists, we should also be aware of these things for the future.
Agreed.
Okay.
Dr. Sujan, any comment?
Mhm.
I think we lost him. Or is he still there? Dr. Sujan? Anyway, thank you very much. It was wonderful presentation by both the students, and we had a nice discussion. Particularly the journal club was really, really very, very impressive. So was the first presentation on the IBD. Yes, Mr. Singh, we are back.
Thank you very much, Dr. Anup and Dr. Deepti.